Treat and extend regimens have been used for thousands of wet AMD patients. How does brolucizumab stack up when compared with aflibercept in a matched treat and extend study?
I'm Greg Notstein here with Scott Chris-Juanes, and this is New Retina Radio's coverage of the 2022 ASRS annual meeting. New Retina Radio spoke with Dr. Carl Regillo, a member of the TALON study group, which sought to find out if brolucizumab was superior to aflibercept for extending treatment intervals in wet AMD patients.
We also spoke with Dr. Carl Danzig, whose work on the TRUCKEE study illuminates real-world treatment dynamics when it comes to the use of faricimab in wet AMD treatment. How are patients responding in the real world? Stick with us to find out. Treat and extend protocols are effective methods of managing treatment burden for some patients with wet AMD. Could particular anti-VEGF agents be more effective than others if this regimen is used? At the ASRS annual meeting in New York, Dr. Carl Regillo shared data from the TALON study, which sought to explore that very question. He's here with us today. Dr. Regillo is with Mid-Atlantic Retina in Philadelphia. He's also with Wills Eye Hospital, where he is director of the Retina Service, and Thomas Jefferson University, where he is a professor of ophthalmology. Dr. Regillo, welcome back to New Retina Radio.
Thanks so much, Scott. Pleasure to be here.
Before we get to the design and the primary outcome results of the TALON study, can you tell us what the TALON study aims to explore?
The TALON study is an ongoing, very large, global, 64-week, two-arm, double-masked, multi-center active control study. And this study was a superiority study in evaluating the efficacy and safety of brolucizumab compared to aflibercept using a matched treat and extend treatment regimen in patients with neovascular AMD. Underscore the notion that it's matched. So both arms in the study have an identical treat and extend treatment algorithm.
Talk to me about the value of treat and extend regimens in the real world and why they're so attractive to so many patients and clinicians.
Yeah, treat and extend as a form of managing wet AMD with our anti-VEGF agents are really is sort of well entrenched, if you will, in what we've been doing now for years, because it's probably the best way to get the best results in the most efficient and least burdensome fashion. So it's probably the best balance between trying to minimize both overtreatment and undertreatment. You know, if you treated everyone every 4 weeks, you probably have very good vision results on average. And yet treat and extend allows you to individualize and extend the treatment interval in many of our patients and still get comparable vision outcomes. And that's been validated at phase 1 level of evidence in multiple studies now. So what we're doing in practice really does work as long as our patients can come in and get their treatments on the schedule that best suits them. Unfortunately, everyone talks about real world results with subpar vision outcomes, and that's true. But that's just the reality of patients outside the context of a clinical trial, because they get sick, problems occur, there's snowstorms, you name it, and they can't get in when they need to get in for these timed injections.
Let's get back to the TALON study itself. It's an international effort. We're talking about 20 countries, 118 sites that are enrolling patients. What more can you tell me about it?
Well, it's very unique, not only in that we have identical treat and extend treatment arms for the two different drugs we're comparing here, brolucizumab and aflibercept, but it's also a superiority study, and that's why I emphasize that term too. That's unusual because usually we're doing non-inferiority studies, showing that one drug works as well as another, but maybe dosed more frequently or less frequently, maybe showing some other type of advantage. But here we're actually looking to see if brolucizumab is superior in terms of the ability to extend the treatment interval. That's the superiority aspect of the study. So that leads us to two basic objectives and two corresponding co-primary endpoints. So that's what makes this study unique. So the one objective and the main objective was to see if brolucizumab is superior to aflibercept with respect to the duration of treatment intervals at the primary endpoint, which was week 32. And so therefore the endpoint was actually, to show that, was the distribution of the last treatment interval with no disease activity at that week 32 endpoint. And then of course, it'd be moot if you didn't also demonstrate, and there's the secondary endpoint, the second primary endpoint, I should say, which is to demonstrate that brolucizumab is visually non-inferior to aflibercept. You can back off and make something look more durable, but if it doesn't keep the vision gains comparable to your control group, then that's moot. So the second co-primary endpoint was average change in BCVA, best corrected visual acuity, from baseline to the primary endpoint, averaged over weeks 28, 32.
Let's get to the study design, to the nuts and bolts of the TALON study. Who was enrolled and how were they randomly assigned?
So this is a 2-arm prospective randomized clinical trial. Enrolled were patients that had neovascular AMD treatment naive, so newly diagnosed, untreated wet AMD. That's very similar to most major phase 3 level studies that we perform in this setting. And typical best corrected visual acuity entry criteria 2025 to 2200. So we can expect patients with relatively good vision potentially in a study such as this. And this is the now FDA approved doses of brolucizumab 6 milligrams versus aflibercept 2 milligrams, randomized again 1-to-1 to get monthly injections times 3, followed by an 8-week injection, and that constitutes the so-called initiation or induction phase. And that was followed thereafter by the treat and extend phase, where patients could be extended by 4-week intervals out to as long as 16 weeks if the investigator showed or determined that there was no disease activity. It's a very important point here because many of our clinical trials allow for some disease recurrence before changing the dosing interval or the frequency of dosing. Here, we're trying to replicate, or the study was designed to replicate what we do in practice, which is, and we recommended that investigators treat to and maintain a dry macula if possible. So we're really trying to maintain a dry macula in order to optimize not only the initial vision gains, but maintain those gains as best as possible over time. So treat to and maintain a dry macula and a treat and extend treatment algorithm. And that would have been a range of treat and extend from 4 to 16 weeks, but the study was later amended to discontinue patients requiring every 4-week dosing after the initiation phase, based on some safety data from the Merlin study, which emerged later. So ultimately, this study becomes an every 8 to 16 week treat and extend treatment regimen out to week 64, the end of study.
I see. And that still required patients to come in for an evaluation every 4 weeks, not just necessarily to receive an injection, correct?
Yeah, I'm glad you mentioned that because patients who are followed very, very closely, we're pushing the envelope with the treat and extend to 16 weeks for both of these drugs, because studies have indicated that aflibercept, for example, a study I published in the past and others have had some evidence to suggest that that drug can also go beyond 12 weeks in a treat and extend regimen. So we wanted to follow the patients really closely. We didn't want to make sure patients were not losing disease control by pushing at 4-week treatment intervals, but by extending or retracting by 4 weeks and extending out to 16 weeks.
All right, let's get to the results. Again, there are 2 primary endpoints, as you outlined earlier. Let's focus on the first endpoint, which sought to learn if brolucizumab was superior to aflibercept when it came to the duration of treatment intervals.
Yeah, so I can tell you up front, brolucizumab met both primary endpoints. So therefore, it was found to be superior to aflibercept in the distribution of the last treatment interval with no disease activity. So we looked at the spectrum of patients getting treatment at the primary endpoint by week 32, looking at patients in the 4-week, 8-week, and 12-week distribution. And at 4 weeks, there was a lot less patients getting brolucizumab, 26% versus 40% for aflibercept. A little bit less at 8 weeks, 36% versus 40%, and a lot more extended to 12 weeks with brolucizumab at 39% versus 20%. So you can see there's a shift in the distribution for greater intervals out to 12 weeks with brolucizumab, and this was statistically significant and therefore met the primary endpoint of being superior.
As you just said, TALON met its other primary endpoint, which was best corrected visual acuity improvement from baseline, as averaged over weeks 28 and 32. What are some other details you can share with us?
No, you're right on. And in fact, again, you have to show the same vision outcomes. If you don't, then yeah, you can push the treatment interval as long as you want, but you're going to start losing vision. So that's the point here. If you look at BCVA change over time, it's essentially identical, right from 4 weeks all the way out to 32 weeks. The lines are almost superimposable and therefore statistically non-inferior. And that was that second co-primary endpoint.
There were a handful of secondary endpoints. Can you outline those with us?
Yeah, and every wet AMD study, we're looking at disease control, and that's measured by OCT. And in fact, the OCT analysis, which was the central subfield thickness change from baseline to, again, averaged over weeks 28, 32, showed that brolucizumab was once again actually superior. Here, it was statistically significant in terms of greater reduction in central subfield thickness compared to aflibercept. So at that endpoint, the primary endpoint, the mean CSFT, central subfield thickness, change was 167 microns for brolucizumab and 140 microns for aflibercept. And this was also statistically significant. So we can say that now, looking at all the data, brolucizumab lasts longer than aflibercept, results in equivalent vision outcomes with less treatment, and also dries better on average and with less treatment. So you get longer durability, greater durability, and better drying with less treatment.
Of course, we're talking about brolucizumab, so the audience will have some questions about safety data. What did the TALON researchers find when it came to safety among the two treatment groups?
Yeah, so the safety of brolucizumab and aflibercept in the TALON, this phase 3b study, was actually very similar, the safety profile, ocular and systemic, to the phase 3 Hawk and Harrier studies, which led to the approval of brolucizumab, and that was a non-inferiority study compared to aflibercept. And there was an imbalance in adverse events. If you look at the total ocular adverse events, it was a little bit higher with brolucizumab, about 27% versus 22%. And when you look specifically at serious ocular adverse events, there is an imbalance. 2.2% for brolucizumab is 0.5% aflibercept. Look at adverse events, again, ocular adverse events leading to study drug discontinuation was higher with brolucizumab, 4.4 versus 0.3%. And then we can talk about the so-called adverse events of special interest, which came out higher with brolucizumab, 5.5% versus 1.1% with aflibercept.
What specifically is an adverse event of special interest?
Yeah, basically they're inflammatory events of varying degrees of severity that may or may not also include direct retinal changes such as retinal vasculitis or even retinal vascular occlusions. So if you look at all adverse events of special interest, most of it's actually intraocular inflammation. And again, 5.5 versus 1.1 is the imbalance there. And specifically, intraocular inflammation alone is usually not a problem. It usually doesn't result in a permanent decline in vision. But what's more serious and what we are looking closely at are these associated direct retinal vascular events, occlusions. When we look at intraocular inflammation with vascular occlusions, that rate came out to be 1.4% with brolucizumab versus 0.3% with aflibercept. So even aflibercept had one such event, but there is imbalance with more events with brolucizumab. Now, these figures are actually about the same as what we saw at the Hawk and Harrier study. So the safety profile hasn't changed. It's pretty much the same. And it's not quite as good as it is with aflibercept or maybe some of the other anti-VEGFs we've been using. But This drug is now also FDA approved for DME with a similar safety profile. So the FDA has deemed this to be an acceptable safety profile.
Understood. Now, TALON is not over. There's still more coming. Can you give us a preview?
Yeah, I think it's going to get really interesting as we follow patients out, and we'll analyze data later this year on the end of study 64-week results. And that's going to give us an opportunity to see how the treatment intervals change over time as we make attempts to extend out to 16 weeks with both drugs. So we'll get the sort of full picture of the durability profile for both drugs out beyond 1 year. So stay tuned.
Beautiful. Fascinating study. Dr. Regillo, thanks for joining us on New Retina Radio.
My pleasure. Thanks for having me.
Faricimab is one of the newest players in the retina space, and following its approval by the US FDA in January, we're beginning to learn more about the real-world dynamics surrounding it.
How do we learn those dynamics? Why, a study was designed, specifically the TRUCKEE study, data from which was presented at the ASRS annual meeting by Dr. Carl Danzig.
Dr. Danzig practices at the Rand Eye Institute in Deerfield Beach, Florida, which is right outside of Fort Lauderdale. Dr. Danzig, thanks for joining us on New Retina Radio.
Thanks, Scott. Thanks, Greg. It's a real pleasure being here with you guys again.
These types of studies are illuminating as they allow us to better understand how a treatment is actually being applied in the real world. Tell us about the TRUCKEE study, which evaluated faricimab in real-world patients with wet AMD.
Well, the TRUCKEE study is designed as a collaboration of physicians. This is not pharmaceutical company sponsored. This is our own endeavor to show our utilization of faricimab, soon after FDA approval. So what we did, we looked at treatment naive patients, but most of the patients in the TRUCKEE study were those hard to treat patients, the high need patients who required frequent injections due to persistent disease activity. So we looked at the demographics, we looked at the prior treatment history, and with that, we examined the efficacy and safety of faricimab in this patient population.
What can you tell us about some of the demographics of those patients?
Right, so we had a total of 377 total patients, and that was about 421 eyes. Some eyes, were bilateral injections that were treated with faricimab, and it totaled for a total of 770 intravitreal injections were administered. But then what we looked at, specifically, we looked at those patients that had follow-up. So follow-up was defined as a patient who had faricimab injection and came back for his or her follow-up visit. Now, we had that available for 236 eyes, and we looked at the population that had a follow-up with vision of greater than or equal to 2,400. And why do we choose this number? We chose it because we were converting the Snellen chart and the letters read on that chart to EDTRS letters. So it was much easier in doing it in the patients who were 2,400 or better, which was the vast majority.
So among those patients who had at least one follow-up, you looked at, as I understand it, 3 particular metrics. Can you tell us what those metrics were and what you found?
Right. So we looked at, letters. How many letters did they read on the ETDRS letters? And what we found is that, in those 236 eyes, those patients were stable. The vision didn't really change. Half a letter improvement really is stable vision. But we also looked at central subfield thickness. So we took their baseline OCT and then we measured it on follow-up, and we found that there was a small decrease in OCT thickness. So for a difference of about 32 microns. Now, these are patients that are, mostly tough to treat. So if they were stable on, their prior treatment every, 4 to 6 weeks, and they were dry, and now we're switching to faricimab to see if we can later on extend them out, we're not expecting a huge change in OCT thickness. But given that some of these patients were treatment naive and did have some persistent fluid, there was a small gain. And then we also measured PED height, and we found that on the follow-up, it was about 14 micron decrease in PED height.
In the follow-up group, that included patients who were treatment naive. What about when you looked at patients who had already undergone a previous treatment with anti-VEGF, which is to say they had something of a head start?
Right. So these patients, were the majority. So there were 236 patients with a follow-up, but 236 eyes with a follow-up. It was 220 eyes that were switched. Okay. So the vast majority were switch patients. And yes, they had a head start, but they didn't do as well as we would have liked. I mean, they were mostly stable with persistent fluid or dry on a monthly interval, but these patients needed, or wanted to, have fewer injections. I mean, they were getting injected, 9, 10, 11 times a year, sometimes 12. So these patients, their vision also was stable, 0.7 letter gain, less than 1 letter gain. That's stable. Their vision, did not go down at all. Their CST was reduced by almost 27 microns. So that's pretty good in patients who were previously treated. And the PED height decreased by almost 6 microns. And the thing that's important here is that the treatment interval remained the same, approximately 39 days between injections.
And what about safety?
Safety is of paramount importance, in our field. Many physicians are hesitant to implement new therapies until, the safety has been proven in a real world setting. So of those 770 injections, there have been 0 cases of intraocular inflammation. That means no uveitis. There have been no cases of retinal vasculitis. There have been no cases of retinal artery occlusions. And that's excellent to know, though it's very early in our study. There was 1 case of culture positive endophthalmitis that was treated with tap and inject, and that patient vision returned to his baseline.
You shared a few patient cases during your ASRS lecture. Can you quickly summarize those for us?
Right. So my first case I demonstrated or showed was a 94-year-old gentleman whom I have been treating for 9 years. So he was 85 when I met him. He has been getting injections monthly. He was even in a clinical trial for patients with persistent fluid. He had been alternating over the last year or so between aflibercept and brolucizumab, every other month a different medicine, and he still had persistent fluid. His vision was 20/60. 33 days after his faricimab injection, his vision remained, or 36 days, remained 20/60, but this is the first time that the fluid under the fovea had resolved. So for him, even though his vision didn't change, it injected hope into this patient that, hey, I'm 94 years old and there's hope I will not need to have monthly injections. Yes, I will need to keep having injections, but it may not be as frequent. And the patient was happy and hopeful.
There was the case of a patient with intraretinal fluid whose vision improved a little bit after switching to faricimab. Can you tell us about that patient?
Yes, this is a really wonderful case. We all know that intraretinal fluid is, a major cause of decreased vision in wet macular degeneration and also other retinal vascular diseases. So in this case, the patient had 20/70 vision with a CST of 351 microns, had faricimab injected. 39 days later, which was consistent with the prior treatment interval, the intraretinal fluid resolved, the vision improved from 20/70 to 20/50, the CST reduced from 351 to 292. This was an excellent response.
Yeah, it sure sounds like it. The TRUCKEE study is ongoing, it sounds like. When can we expect to hear more from the study group?
So it is an ongoing study, and we are still looking for new sites that want to collaborate with us. But this is an early experience, and we're looking to, add to our study database and one day look at durability. I'm hoping that at the fall meetings, we'll be able to have something to present if we're fortunate enough to have that opportunity. We're still waiting for final confirmation of that. But in the meantime, we're still collecting data, and we do expect that later this year and in 2023, we'll have more data to present.
Dr. Danzig, thanks for joining us, and thanks for coming back on the show.
Always a pleasure. Thank you for having me.
Thanks for joining us on our first episode of ASRS 2022 meeting coverage. Be sure to subscribe to the podcast on Apple Podcasts or on whichever platform you use.
And if you are using Apple Podcasts, please leave us a review. It helps your peers find the episodes. We have 2 more episodes of ASRS coverage. Keep an eye out on your podcast feed.